Good evening, everyone. Today we are going to start the first program of our Neurosciences Forum. We are going to have a series of topics, each topic 1 month. This month we have selected the topic as the brain infection. In our forum, we are going to have two speakers. One speaker will be from the neurophysician and another speaker will be neurosurgeon. So it will be a common topic for both of them to talk. And I like to welcome our speakers of the evening today, Dr. V. Valavan sir, the senior consultant neurophysician from Tirupur, Neuro Center Tirupur, and Dr. Pradeep T, who is the assistant professor of neurosurgery, Coimbatore Medical College, Coimbatore. In this neurosciences forum, our main aim is to improve the knowledge of our postgraduate students. We will straight away start the program with, I invite the first speaker of the day, Dr. V. Valavan sir, to give his talk on brain infection medical. Did his undergraduate from Pott Medical College, MD General Medicine from Coimbatore Medical College, and completed DM Madras Medical College in 2013. Currently running Thirupur Neuro Center in Tirupur. Got Professional Excellence Award by Rotary Elite in 2020 and got Best Doctor Award by IMA in 2022. Presented various topics in national and state conferences. Published serious articles in indexed journals. Area of interest is the neuro-ophthalmology. I invite Dr. V. Valavan sir to give his lecture on the brain infection, the medical management.
Thank you for your nice introduction, sir. Good evening, one and all. So, am I audible, sir?
Yes, sir, audible.
Thank you, Rajesh, sir, for your nice introduction, sir. And he's from our company for giving me this opportunity, sir. Good evening, one and all, for all the participants. I think the stipulated time period, I can't complete the entire topic because the management of CNS is quite spectrum of infections. It may be like starting from virus, bacteria, fungus, cannot be covered in this thing. I try to cover the common things, sir. So this is the outer which I am going to talk today. The first will be meningitis, then second one will be encephalitis, and third one will be brain abscess, then cerebral malaria, and finally, concluding remarks, take home methods. So this is meningitis. So the meningitis can be broadly classified into three ways. One is by the structures involved, and another by the purpose involved. By the structures involved, it can be classified as meningitis.
So the classic symptom of meningitis is the neck stiffness. That is a sign of meningeal irritation. So there are two signs which can elicit the meningeal signs. So one is Kernig sign and another one is Brudzinski sign. So to elicit Kernig sign, place the patient in supine position and ask the patient to flex his lower limb, both at knee and hip, and then passively extend the knee. If the patient is having spasm or pain in the hamstrings, that is indicative of meningeal irritation. It's a sign of meningitis. And another classical sign is Brudzinski sign. So in this, to elicit this sign also, the patient has to be lie down in the supine position. And when the patient neck is flexed, flexion of the knees and hip is produced. And by the way, in the other way, if the lower extremity of one side is passively flexed, a similar movement is observed in the opposite extremity. So the sensitivity of these two signs, that is the Kernig sign is 42%, whereas the Brudzinski sign is 97%. Apart from these two signs, we are having another sign, that is head jolt test, that also can elicit meningeal irritation. In this test, the patient is asked to move their head back and forth in the horizontal plane at a rate of 2 to 3 turns per second. If the headache worsens, that indicates the patient is having meningeal irritation. So after completing the symptomatology, now we are coming to etiology. the most of the meningitis are caused by viruses. That is approximately 50% are caused by virus. Among the viruses, the enterovirus is the commonest, followed by herpes simplex and varicella zoster. And the common and deadliest meningitis is bacterial meningitis. Among the bacteria, the Streptococcus pneumonia and Neisseria meningitis, these two organisms totally account for 25% of the total meningitis. Apart from these two organisms, the other organisms involved in meningitis are Haemophilus influenza, Listeria monocytogenes, Mycobacterium tuberculosis, and fungi. These are less frequently detected. Historically, the Haemophilus influenza was the most common organism previously. Because of hip vaccination, the incidence of Haemophilus influenza meningitis has come down recently. So, I already told that the virus is the commonest organism which causes meningitis. These meningitis can be diagnosed by two ways from the spinal fluid. So the one way is PCR from the spinal fluid, that is polymerase chain reaction, and other way is CSF serology. So by PCR technique, we can diagnose herpes simplex type 2, enterovirus, human parachovirus, varicella zoster virus, cytomegalovirus, and LCMV. By CSF serology, we can diagnose West Nile, mumps virus, and La Crosse encephalitis. So if the patient is having clinical signs and symptoms of meningitis and the patient is having rashes in his body, so the three common organisms most likely are Neisseria meningitis, varicella, and enterovirus. Among these three, Neisseria meningitis is the most common organism. So we are having clinical suspicion of meningitis. Then what to do? Whether we have to go for imaging or whether we have to go for LP straight away or we have to give antibiotics straight away. So in cases suspicious of meningitis, LP should be done immediately if there is no clear contraindication. That is the most and foremost important investigation in the case of suspicious meningitis. If in the clinical suspicion for bacterial meningitis is high, empiric antibiotics should be started immediately when the LP cannot be performed, because there are some relative and absolute contraindications for immediate LP. So these are the common indications for brain imaging prior to LP. So if the patients are having focal neurological signs, presence of papillary edema, continuous or uncontrolled seizure, GCS less than 12. And apart from these, if the patient is having signs of severe sepsis or rapidly evolving rash, respiratory or cardiac compromise, if the patient is already on anticoagulant therapy, or infection at the site of lumbar puncture. These are the relative contraindications for immediate lumbar puncture. Yes, we took the CSF, and what are the things we are going to see in the CSF? So if possible, the opening pressure should be measured, and almost always in case of bacterial meningitis, it is high. The normal CSF pressure, opening pressure is 12 to 20 centimeters of water. So apart from the opening pressure, the CSF should be sent for microscopy, culture and sensitivity, protein and glucose estimation in the CSF, lactate. Then apart from this, PCR or serological testing for specific organisms. Apart from these CSF investigations, we are having one more foremost investigation, that is procalcitonin. In the setting of suspected meningitis, but a negative CSF gram strain, still we are having clinical suspicion of bacterial meningitis. In those cases, we have to do serum procalcitonin. If the serum procalcitonin level is more than 0.98 nanogram per ml, it is highly suspicious that it can differentiate bacterial meningitis from viral meningitis. The sensitivity of the test is 87, the specificity is almost 100%. We took the CSF and we sent to the lab. So what are the CSF findings we will get? In the bacterial meningitis, the CSF leukocyte count is almost more than 100 cells per microliter. But on the contrary, absence of pleocytosis does not rule out bacterial meningitis. There are some conditions where there will be no pleocytosis, but the patient is having meningitis. We will discuss it later. Approximately 1 to 2% of patients with bacterial meningitis will have a normal CSF leukocyte. So, children, immunocompromised individuals, those pre-treated with antibiotics, and those patients with Mycobacterium tuberculosis infection, these patients will be having positive pathogen detection, but there will not be pleocytosis in CSF. Apart from these, blood CSF glucose estimation is very, very important because it can differentiate between bacterial and viral meningitis. If the CSF to blood glucose ratio is less than 3.6, 0.3.6, it is an accurate marker for distinguishing bacterial from viral meningitis. The normal protein level in the CSF is less than 0.4 gram per liter. Elevated protein suggests inflammation. A CSF protein less than 0.6 gram per liter largely rules out bacterial infection because in bacterial meningitis, the protein elevation is much higher than this. So in the nutshell, the normal opening pressure is 12 to 20 centimeter of water. In the viral is almost same as normal, except the cell count will be elevated by 5 to 1000, and the predominant cell type in viral meningitis 5 to 1000. That is lymphocytes. The CSF protein is mildly raised, whereas in the bacterial, the appearance is very much cloudy. The protein is much elevated than other thing, like it should be more than 100. The predominant cell type is neutrophils, and the CSF protein is raised. The tuberculosis is very classical because the protein elevation is very much raised and the CSF plasma glucose ratio is very low. Fungal is almost similar to bacteria. So in the nutshell, predominance of neutrophils in the CSF suggests bacterial meningitis, whereas on the contrary, predominance of lymphocytes in the CSF suggests viral meningitis. There are few exceptions for this rule because predominance of lymphocytes in bacterial meningitis can occur if the patient already received antibiotics prior to LP and with certain bacteria like Listeria monocytogenes and tuberculous meningitis. As in bacterial meningitis, in the viral meningitis, predominant cell type is lymphocytes, but in subtle viral infections like enterovirus, the predominant cell type is neutrophils. So this is the classical imaging of meningitis. This is T1 contrast axial image showing leptomeningeal enhancement bilaterally. Yes, we diagnose and we took the LP and CSF is sent to the laboratory. Then what to do? Whether we have to start antibiotics or we have to wait for the results? No. There is a 3-tier treatment for suspected bacterial meningitis. Step 1, if the patient is having suspicion of bacterial meningitis, the antibiotic should be started immediately without any delay. Step 2, after the gram stain. Step 3, after the PCR or culture reports. Now we will come to the step 1. So there is a clinical suspicion of bacterial meningitis. The patient, because the commonest organisms are Streptococcus pneumonia or Neisseria meningitis. So straight away start the patient on appropriate antibiotics. That is ceftriaxone 2 gram IV 12 hourly or cefotaxime 2 gram IV 6 hourly. If the clinical suspicion is meningococcal sepsis and the patient has not received ceftriaxone, then give a single dose of ciprofloxacin. In patients at risk for Listeria monocytogenes, because certain individuals are at risk for Listeria monocytogenes, like alcoholic patients, severely immunocompromised, and the age more than 65. These are the individuals who are more prone for Listeria monocytogenes. In these patients, apart from ceftriaxone or cefotaxime, we have to add ampicillin or amoxicillin in addition to those antibiotics. Yes, we completed step 1. Now we are coming to, we received the gram stain reports. What to do? So if the gram stain showing gram-positive diplococci, the likely pathogenic organism is Streptococcus pneumoniae. You just continue as step 1A, like you have to continue with ceftriaxone or cefotaxime. If the patient visited a country that have penicillin resistance, then add vancomycin, that is 15 to 20 milligram per kg IV 12 hourly until resistance data available. Alternately, rifampicin can be given, or if the patient is having renal failure, instead of vancomycin, straight away go for rifampicin in addition to ceftriaxone and or cefotaxime. If the gram stain is showing gram-negative diplococci, the likely organism is Neisseria meningitis. In these patients, just continue ceftriaxone or cefotaxime. That's all. If the gram stain showing gram-positive bacilli, so probable organism is Listeria monocytogenes, you just continue a step 1A like this. You have to continue cefotaxime or ceftriaxone. Plus, you have to add ampicillin to cover Listeria monocytogenes. The dose is 2 gram IV 4th hourly. in addition to ceftriaxone or cefotaxime. If the gram sign showing gram-negative rods, the probable organism is Enterobacteriaceae. So in this also you have to continue step 1A. But if the patient is having extended spectrum beta-lactamase resistance, you have to stop ceftriaxone or cefotaxime. Then you have to replace with meropenem 2 gram IV 8 hourly. This is the appropriate dose for gram-negative rods. So these are the same thing, but the only thing is in this slide we have to come to the duration of the treatment. If the organism is Streptococcus pneumoniae, we have to treat with ceftriaxone, vancomycin for day 10 or day 14. That is 10 to 14 days we have to complete the treatment. In case of Neisseria meningitis, we have to cut short the treatment, then it can be stopped by the day 5. If the pathogenic organism is Listeria monocytogenes, then we have to continue for 21 days. If the pathogenic organism is Haemophilus influenza, then treatment duration is 10 days. If it is Enterobacteriaceae, we have to continue for 21 days. So in the nutshell, Listeria monocytogen, Enterobacteriaceae has to be, the antibiotic has to be given for 21 days. So what is the timing of appropriate antibiotics? So the delay of over 2 hours in antibiotic administration in a case of bacterial meningitis, the mortality is doubled. So wherever possible, the antibiotic should be administered as soon as possible and certainly within 2 hours of the suspicion if the patient is having any sepsis. So what is the role of steroids in case of bacterial meningitis? The current recommendation is intravenous Dexa 10 mg 6th hourly should be commenced on admission or shortly before. This on admission shortly before or simultaneously with antibiotics, and up to 12 hours after the antibiotics can be given. So it should not be delayed because it is very much useful in pneumococcal meningitis. If the pathogenic organism is pneumococcal meningitis, the dexamethasone should be continued for 4 days. In other organisms, the role of steroids is not yet well established. So what are the new treatments? So in spite of all this aggressive medical management, the patient is still having the mortality of bacterial meningitis 10 to 20% because of the increased inflammation. So the current trials are aimed at reducing inflammation. The 2 drugs are in trial. One is daptomycin. It is primarily being used for its anti-inflammatory properties rather than its antimicrobial properties. And apart from this daptomycin, and another drug is adjuvant treatment with C5 inhibitors, which downregulate the complement-mediated inflammation. So after completing meningitis, now we are coming to encephalitis. So encephalitis is the inflammation of the brain parenchyma. So in encephalitis, patient is having features of encephalopathy. Apart from that, one inflammatory feature. What is encephalopathy? Encephalopathy is defined as altered consciousness that is persisting for longer than 24 hours, including lethargy, irritability, or a change in personality or behavior. With encephalopathy, patient should have at least 2 of the following features. That is fever, seizures, or focal neurologic finding attributable to the brain parenchyma, CSF pleocytosis, that is more than 4 white cells per microliter, in abnormal EEG and abnormal imaging findings. In this also, the common organisms are virus, herpes simplex virus type 1, 2, varicella zoster, enterovirus, adenovirus, parachovirus, measles virus, and HIV. Apart from the infectious etiology, there are some other etiology which is nowadays increasing in incidence. That is autoimmune encephalitis. So among the autoimmune encephalitis, the quite common thing is NMDAR antibody encephalitis. It is usually associated with ovarian teratoma, and LGI1 antibody encephalitis and anti-HU-MA. These are all the other autoimmune antibodies that can be seen normally. Apart from this infective etiology, there are some close mimickers of encephalitis. In the mimickers, it is infective, inflammatory, metabolic, neoplastic, others. Infective, we are, apart from viral, we are having bacterial meningitis, TB and opportunistic infection like fungal infections. In the inflammatory, SLE, Behçet, Neurosarcoidosis. These are the common things which can mimic encephalitis, infective encephalitis. In the metabolic component, we are having hypocalcemia, hyponatremia, hepatic encephalopathy, and toxics. And some primary and metastatic tumors can mimic encephalitis. And others like status epilepticus or psychiatric disease or even simple hemorrhagic or ischemic stroke can mimic encephalitis. So among the encephalitis, which is the HSV is one of the commonest and it easily treatable. If we are giving appropriate antiviral agent, the mortality can be reduced. So now I am going to deal with HSV encephalitis. Each and every virus has got a predilection for a particular site in the brain. So like this, in the herpes simplex virus has a predilection for temporal lobes and frontal lobes. So if the structures in the temporal lobe and frontal lobes are involved, we are having these features like personality changes, psychosis, olfactory or gustative hallucinations, acute episodes of terror attacks, upper quadrant visual field defects, difficulty in storing or recalling newer information, hemiparesis with greater involvement of the face because the lateral convexity is involved, face and aphasia when the dominant hemisphere is involved. Apart from HSV, there are some other viruses like West Nile virus, Eastern encephalitis virus. These viruses have predilection for basal ganglia. So the symptomatology will be tremors or other movement disorders. And in the Bartonella hensale, Mycobacterium tuberculosis, enterovirus, flavivirus, alphavirus, these viruses and these bacteria have predilection for brainstem. So the presenting symptoms and sign will be autonomic dysfunction, lower cranial involvement with respiratory disturbances. Two distinct neurologic clinical conditions can arise with EBV encephalitis. Epstein-Barr virus is one of the herpes virus family virus. So in this, the patient will be present with opercular syndrome or Alice in Wonderland syndrome. In opercular syndrome, the patient will be having paralysis of facial, pharyngeal, and masticatory muscles. In Alice in Wonderland syndrome, the patient will be presenting with alteration of visual perception characterized by distortion of the images. So what are the characteristics CSF finding in a case of encephalitis? In the encephalitis also, the protein is bit elevated, not comparing with meningitis, and there will be pleocytosis, not as much as in meningitis, but the PCR is quite characteristically very positive in HSV encephalitis because the sensitivity and specificity of PCR for HSV is 95% for HSV encephalitis in immunocompetent adults. In some cases where CSF is obtained very early in the disease course, PCR may be negative. If the clinical suspicion of HSV remains high, LP should be repeated and definitely it will be positive. Apart from CSF, there is some classical features which can tell us that it is herpes simplex encephalitis. Because I already told that each and every organism has a predilection for a particular site in the brain. Likewise, the HSV encephalitis, the characteristic involvement is medial temporal lobe and frontal lobe. In this picture, it's a flare axial image. This patient is having HSV encephalitis. Bilateral medial temporal lobes are involved in this patient. That is left more than right. Yes, we diagnosed with the CSF and imaging finding it's HSV encephalitis. What we are going to offer to that patient. So that drug of choice is intravenous acyclovir. That is a life-saving treatment in HSV encephalitis and has reduced the mortality from 70%, 10 to 20%. Whenever we are giving acyclovir, the patient should be hydrated well because it is toxic to renal tubules. So the renal function should be monitored. In patients with non-renal impairment, the dose should be reduced. However, if LP is delayed for more than 6 hours, don't worry. You please start acyclovir in these patients. So what is the optimal duration of the treatment? That is acyclovir. So the guidelines recommend that acyclovir should be continued for at least 2 weeks, at which point the LP should be repeated. If the HSV PCR is still positive, acyclovir should be continued with repeat LP every week and if till the PCR is weak. There are some contradictions in this point. In some articles, they told that if the patient clinically improved, if the PCR is still positive, don't offer acyclovir. You can stop by 2 weeks. The most significant factor determining the outcome in HSV encephalitis is starting antiviral treatment. What is the when you are going to start? That is as early as possible, ideally within 6 hours of the presentation. Two factors significantly associated with poor outcome in HSV encephalitis are how sick the patient was at presentation. That is SAP score more than 27 and the initiation of acyclovir. If it is more than 2 days after the initial presentation, it will be very detrimental to the patient. After completing encephalitis, now we are going to discuss about brain abscess. The brain abscess will be dealt very nicely by subsequent speaker because it is a mostly neurosurgical topic. A brain abscess is a collection of purulent material resulting from infection within the brain parenchyma. It starts with like encephalitis, like focal inflammation and edema, that is called early cerebritis. Then this inflammation expand and progress over days to a wider area, and it will be surrounding an increasingly necrotic core. In the course of few weeks, collagenous capsule surround the necrotic core. It will be walled off. So it will be seen nicely in the imaging. What is the incidence of brain abscess? It is approximately 0.4 to 0.9 per 1 lakh populations. It is higher incidence is noted in immunocompromised populations. Most of the affected patients are men, and in their third or fourth decade of life. The mortality from brain abscess has historically run as a 40%, but has decreased to 10 to 20% since 2000 because of the modern modality of medical and surgical managements. So what are the commonest organisms which is involved in brain abscess? In this also, like gram-positive organisms, like it is a mixed organisms. Gram-positive, gram-negative, and even anaerobes are involved in brain abscess because it may be involved by the contiguous spread from otomyositis, sinus infection, and dental infection, or it may be hematogenous spread from a distant site like pulmonary, liver, or abdomen, even abdomen. So the commonest organisms in brain abscess are Streptococcus, Staphylococci. In gram-negative bacteria, we are having Proteus species, Klebsiella species, E. coli, and Enterobacteriaceae. Nearly 25% of all brain abscesses are polymicrobial in nature. In immunocompromised patients, we are having nocardia and fungal infections will be present in immunocompromised individuals. So this also, like meningitis, it's a classical triad is there in brain abscess: headache, fever, and focal neurologic deficits. So what is the investigation of choice in case of brain abscess? In this also, MRI brain with gadolinium contrast is the investigation of choice because it detects early cerebritis stage, and the posterior fossa structures can be very nicely visualized by the MRI rather than the CT scan. So blood culture can aid with identifying a causative organism in 25% of cases. Yes, we are having brain abscess. Then what to do? So it is managed by multidisciplinary approach, both by physician and surgeon. So the empiric broad spectrum antibiotic therapy should be offered to cover Staphylococcus, Streptococcus, gram-negative organisms, and anaerobes. That is combination of vancomycin, third generation cephalosporins, and metronidazole. So in this, the duration of antibiotic therapy is quite high because we have to give antibiotic for at least 6 to 8 weeks, and we have to monitor by neuroimaging. And most of the brain abscesses are dealt by neurosurgical department. Usually, they will drain the abscess. There are some techniques. So after completing brain abscess, now we are going to discuss neurocystic sarcosis. So the causative organism is Tinea solium. So there are 4 stages in neurocystic sarcosis. The first stage is vesicular, and second stage is colloidal, and third stage is nodular, granular, and the fourth and final stage is calcified. In the vesicular stage, we used to see in the imaging cyst and scolex. In the second stage, that is colloidal, ring enhancement and edema will be present. Third stage, nodular granular, there is decreased enhancement and edema, but initiation of calcification will be there in the third stage. In the fourth stage, calcification on CT or MRI imaging. So the 2 most common clinical presentation of neurocystic sarcosis are, one is seizure and another one is increased intracranial pressure. So what is the ideal test to diagnose neurocystic sarcosis? It is serologic testing. It is serologic testing with enzyme-linked immunotransfer blood. That is the confirmatory test in a case of neurocystic sarcosis. All the patients with neurocystic sarcosis should undergo a fundoscopy examination prior to initiation of anti-helminthic therapy. So the neurocystic sarcosis, the site may be variable. the number of cysts may be variable, the stage of the lesion may be variable. So we are going to deal what is the treatment for each and every stage and for the location. If the patient is having viable parenchymal lesions, that is, the lesion is 1 to 2 viable cysts, we have to give only monotherapy, that is albendazole, that is 15 milligram per kg per day in 2 divided doses with food for 10 days. If the patient is having more than 2 viable cysts, then we have to add 2 anti-helminthic therapy. One albendazole, that is the 15 milligram per kg per day in 2 divided doses. With that, we have to add praziquantel, that is 15 milligram per kg per day in 3 daily divided doses. The duration of therapy is the same, like 10 days. So, have we to give anti-inflammatory therapy, that is corticosteroid should be given? Yes, we have to give whenever anti-parasitic drugs are used. Anti-epileptic therapy? Anti-epileptic drug should be used in all patients with seizures. If the patient is having single enhancing lesion, then what is the treatment of choice? So the anti-parasitic therapy should be offered, that is albendazole monotherapy, and the anti-inflammatory, because we are giving anti-parasitic treatment, we have to continue with corticosteroids. And anti-epileptic therapy, as we said already, anti-epileptic drug should be used in all patients with seizures. If the patient is having calcified neurocysticercosis with or without perlesion edema, no need for anti-parasitic therapy. So not we are giving anti-parasitic, no need for corticosteroids. And anti-epileptic therapy, if the patient is having seizures, then we can give, otherwise no need. If the patient is having intraventricular cysts, then we have to offer surgical management that can be removed very nicely. If it is not removable location, if it is present in the non-removable location, then we have to offer shunt surgery. Malaria. So, cerebral malaria is a symmetric, diffuse, potentially reversible encephalopathy caused by Plasmodium falciparum. Because Plasmodium species, there are 4 species. Among the 4 species, Plasmodium falciparum causes the cerebral malaria, which is very, very dangerous complication of malarial infection. So here is the life cycle of malaria. So simply, the cycle in human starts with the hepatic cell and it ends with the gametocyte formation in the blood. And in the mosquito, it starts with a microgamete injection from the humans and ends with sporozoite that is inoculated in the human. The female Anopheles mosquito is the vector for the disease. So what is the criteria to say cerebral malaria? So the patient should be positive for Plasmodium falciparum by thick and thin smear. GCS should be less than 11 and or blantyre less than 2 in children. Exclusion of other convulsive post-critical state or hypoglycemia, and exclusion of other causes of coma like encephalitis, encephalopathy, trauma, or toxicity. Usually, the first symptom occurs after the bite, that is 10 to 15 days after the bite. So, what are the first symptoms? The first symptom will be high-grade fever, myalgias, headache, sweating, and other typical manifestations of a flu syndrome. Other reported manifestations are nausea, vomiting, abdominal pain, tachycardia, arthralgias, and hepatosplenomegaly. Diagnosis must be confirmed by thick and thin microscopy with 1000 times magnification and James time, after which the species can also be identified by the thin smear. Other techniques, there are PCR and rapid qualitative tests for the detection of antigens that detect PF-HRP2 and PLDH of Plasmodium falciparum. That is also having a diagnosis similar to the method by the microscope. Says the patient is having clinical cerebral malaria. So what is the treatment that we are going to offer to that patients? So the ideal treatment is, the treatment of choice are intravenous drugs like artesunate and quinine. These are the drugs of choice. Among these, artesunate scores over quinine because the low toxicity and ease of administration, greater efficacy because it acts all stages of the parasitic cycle, whereas the quinine acts only on the late stages of the parasitic cycle. So artesunate reduces the mortality by 34.7% compared to quinine. So whenever possible, artesunate should be given rather than quinine. What are the factors that give the prognosis to the cerebral malaria? If the patient is having recurrent seizures, absence of corneal reflux, decerebration, retinal hemorrhages, patients under 3 years, high levels of parasitemia, that is more than 20%. If the patient is having lactic acidosis, if the CSF lactate is elevated, there is transaminitis, if the patient is having low antithrombin 3. These are the factors which prognosticate the patient, whether the patient will survive or the patient will be very bad in situation. So, concluding remarks, these are the few take-home points. So, in a case of acute bacterial meningitis, whenever it is suspected, LP should not be delayed and yearly empiric antibiotic administration should be started. In the context of negative gram stain, serum procalcitonin may be helpful in differentiating between bacterial and viral meningitis. So IV dexamethasone should be started immediately before or simultaneously with the antibiotics in a case of bacterial meningitis. IV acyclovir should be given in case of suspected encephalitis without waiting for LP or PCR results. Treatment of NCC varies according to location, stage, and number of cysts. Fungi should be seen in case of NCC before starting antiparasitic therapy. In case of cerebral malaria, IV artemisinin derivatives are preferable over quinine. Thank you.
Thank you. Thank you so much, Dr. Valavan sir. It was an exhaustive.
Good evening, everybody. Very nice to have our Dr. Pradeep, who is an assistant professor in the Department of Neurosurgery, Coimbatore Medical College, a dynamic neurosurgeon and a versatile neurosurgeon, handles all aspects of neurosurgery. It's a great pleasure for us to have you with us with abundant knowledge from the Coimbatore Medical College.
Your previous slide, Burga.
Give us this lecture, sir. He has qualified neurosurgery M.Ch with 8 years of experience, and he has received the Best Doctor Award from District Collector of Coimbatore in 23. He has several international journals contributed as a co-author and author. Next slide. Welcome and give us enlighten us about the surgical aspects of spine and brain neuroinfections.
Thank you, sir. Thank you for the introduction. Good evening, everyone. I'll straight away go to the topic. The topic is brain infections, surgical management. Infectious diseases of the CNS are classified into diffuse and focal forms. Diffuse forms includes meningitis, meningoencephalitis, encephalitis, myelitis, radiculomyelitis, or myeloencephalitis. And focal lesions include granulomas, suppurative collections, and cysts. And it can also include scalp abscesses, cranial osteomyelitis, intracranial infections. Regarding the source of infection, the causative the source of infection spreads through 3 routes. One is extension from contiguous sites of adjacent infection. Other one is post-traumatic or post-surgical direct inoculation. The third one is from a distant site via hematogenous spread. Then the neurosurgeon's role in diffuse lesions of the CNS. It is to provide tissue by biopsy and CSF for diagnosis and surgical management of increased intracranial pressure. Neurosurgeon's role in focal lesions of CNS is to obtain tissue sample for definitive diagnosis by stereotactic or by image-guided biopsy, aspiration or excision of the space-occupying lesion or reduction of its mass effect, decompressing neural structures, CSF shunting against symptomatic hydrocephalus, and debriding infected and necrotic tissue when infection persists or worsens despite appropriate antimicrobial regimens. The anatomical locations of cranial infections are classified based on scalp, skull, dura mater, arachnoid mater, pia mater or brain parenchyma, and orbit. When it comes to scalp, the diseases are named as subcutaneous abscess, cellulitis, subgaleal abscess, and draining sinus tract. In the skull, when the bone is involved, it is osteomyelitis, and when the extradural space is involved, it is extradural or epidural abscess. When the dura mater is involved, it is subdural empyema or dural sinus thrombophlebitis. When the arachnoid matter is involved, it is arachnoiditis or pachymeningitis. When the subarachnoid space is involved, it is meningitis. When the pia mater or brain parenchyma is involved, when the pia is involved, it is cortical venous thrombosis. When brain parenchyma is involved, the focal lesion is brain abscess and the diffuse lesion is encephalitis. And in terms of ventricle, it is ventriculitis or pyoventriculitis. And when the orbital space is involved, it is orbital infections. Infections of the brain and its coverings are it comes under various headings. There are scalp abscesses, cranial osteomyelitis, cranial epidural abscess, cranial subdural empyema, post-traumatic meningitis, brain abscess, infective encephalitis, orbital abscess, Pott's Puffy tumors, surgical site infections in cranial surgery, brain tuberculomas, brain hydrated disease, parasitic and fungal infections. We'll start with scalp abscesses. Infections of the scalp may involve any of its 5 layers: skin, connective tissue, aponeurosis, loose connective tissue, and pericranium. Most infections are superficial, minor, and limited, but they can extend and induce more serious complications such as necrotizing fasciitis and cranial osteomyelitis. Scalp abscesses are uncommon purulent infectious collections involving principally the subgaleal space under the aponeurosis or epicranium. Coming to CT and MRI findings, they are used for detection and confirmation of diagnosis, for evaluation of the severity of infection and its extension. The appearance is that of a fluid collection with peripheral enhancement following contrast injection. Neurosurgeon's role is to drain the subgaleal abscess, to obtain intraoperative cultures for culture sensitivity, and to remove the necrotic tissues. Coming to cranial osteomyelitis. Osteomyelitis is an inflammatory condition of the bone and bone marrow, which is mainly caused by pyogenic bacteria. The classic clinical picture of cranial osteomyelitis is with local infection, with or without general signs of infection. The local signs of infection are swelling, pus formation, purulent fistula, and discharge with a foul odor. The cranial bone may also be exposed. General signs of infections are fever, chills, fatigue, lethargy, irritability, headache, and lymphadenopathy. There are 5 main types of skull osteomyelitis from type 0 to type 4. Type 0 is initial cranial bone involvement, and type 1 is limited to cranial bone. Type 2 is extracranial extension. Type 3 is intracranial extension. Type 4 is cranial, extracranial, and intracranial extension. Meningitis and neurological syndromes should alert for intracranial extension and complications. And if the duration of the symptoms is less than 1 month, it is considered as acute infection. CT scan, it has 2 stages, acute and chronic stage. Coming to acute stage, it shows area of rarefaction and loss of diploic bone trabeculae, demineralization, erosion or thinning of the cortical bone table, and extracranial and subperiosteal abscesses. Coming to chronic stage, it will be diploic bone sclerosis and cortical bone thickening that may be mixed with area of radiolucency and interruption of cortical bone. Sequestered formations are combined with more or less extensive destruction of skull tables. MRI, actually osteomyelitis, gold standard is CT brain. MRI is useful in demonstrating intracranial extension, especially epidural abscess with subdural empyema. Bone scans like technetium-99, gallium-67 citrate, SPECT, PET, and FDG PET are very sensitive, and they detect bone involvement in early stages. Neurosurgeon's role, again, surgical debridement remains a critical thing to eliminate areas of necrosis and sequester. Infected bone with evidence of necrosis should be removed, followed by cranioplasty on a second intervention. The case of bone infections, both CT and MRI may take months to years to return to normal in the postoperative period to show resolution of the cranial bone infection. Next, coming to cranial epidural abscess. Cranial epidural abscess is a purulent collection developing between the dura mater and the cranial bone. Some characteristics specific to cranial epidural abscesses are because of its relative isolation of brain parenchyma and the insidious development of the infection. These abscesses usually reach a large size at diagnosis, and the adherence of the dura mater to the cranial bone can limit the expansion of the epidural abscess. In the CT scan, it appears as a poorly defined lentiform or biconvex collection with low or intermediate density. After contrast injection, the convex inner side of the low density lesion becomes enhanced. Neurosurgeon's role: patients with small or limited epidural abscess without neurological complications can be treated with antibiotics, but most cases require Burwell craniotomy if the patient has not improved clinically despite receiving appropriate intravenous antimicrobial therapy. The dura should not be opened to avoid any meningitis or deeper suppuration. Cranial subdural empyemas. Cranial subdural empyema is a purulent collection developing between dura mater and the arachnoid membrane. It causes inflammation and edema of the adjacent brain, septic thrombophlebitis, and venous infarction, which can rapidly expand into the subarachnoid space and the brain parenchyma. Subdural empyema represents a surgical emergency, so craniotomy and rapid evacuation of the purulent collection are obligatory as soon as it is diagnosed. Subdural empyema is more fulminant and fatal than epidural abscess. Subdural empyema secondary to chronic subdural hematoma is a well-known infectious complication. Symptoms are due to mass effect, inflammatory involvement of the brain and meninges, and thrombophlebitis of the cerebral veins and dural venous sinuses. In CT, it appears as a low-density crescent-shaped collection over the brain hemisphere or along the falx with internal displacement of the gray-white junction and the medial structures. The peripheral margins are better demarcated after contrast injection, particularly along the medial border of the collection at the pile surface. In MRI, it appears iso-intense to hypo-intense on T1 weighted images, hyper-intense on T2 weighted images, and it shows high signal on diffusion weighted imaging. This is the left one is a CT with contrast, and the right one is an MRI with contrast. Neurosurgeon's role. Surgical management is indicated in almost all cases of subdural empyema for cerebral decompression, drainage of purulent material, and identification of the causative bacteria. Surgical procedures include Burwell drainage, stereotactic drainage for deep-seated parafalcine or tentorial empyemas, and craniotomy for irrigation, debridement, and drainage. Purulent material tends to be in a fluid state early in the disease course, so pus may be more amenable to Burwell drainage, and it may become loculated and require craniotomy at later stages. An external ventricular drain should be placed to prevent CSF obstruction in some patients with obstructive hydrocephalus. The CSF drainage will be either gradually withdrawn over time or removed or replaced later by a definitive shunt. Coming to post-traumatic meningitis, dural tear and cerebrospinal fluid leakage are major risk factors for post-traumatic meningitis. Fractures involving the skull base and the paranasal sinuses have the potential for the subsequent development of a transient or persistent CSF leak. Early meningitis occurs within 2 weeks following injury. Penetrating head injuries with dural laceration are also associated with increased chances of meningitis. Axial CT scan will often show pneumocephalus. Thin slice CT imaging with sagittal and coronal reconstruction will often show the site of the bony defect. Coming to MR cystoscopy shows a T2 hyperintense column of CSF communicating between the subarachnoid space and the sinuses. CT cystoscopy shows contrast extravasation through a bony defect and pooling in a paranasal sinuses. CSF analysis shows increased protein and decreased glucose level, helps in identifying the pathogen. The best lab tests for identifying the presence of CSF in nasal or ear fluids are beta-2 transferrin assay and beta-trace protein. Management of CSF leak before surgery or bed rest, hydration, medication with steroids or acetazolamide, lumbar tapping, and spinal drainage. When patient does not respond to the above treatment, then there comes the neurosurgeon's role, where the neurosurgeon has to repair the defect site either by open intracranial surgery or by an endoscopic procedure of the skull base. Post-meningitic hydrocephalus may develop, which may require CSF diversion. Brain abscess is an intracerebral suppurative collection. It spreads by contiguous and hematogenous spread. Contiguous spread is from paranasal purulent sinusitis, middle ear or mastoid air sinus infection, odontogenic infections. Hematogenous spread can be from lung abscess, bronchiectasis, empyema, congenital cyanotic heart disease, pulmonary AV fistula, and endocarditis. Stages, there are 4 stages of brain abscess. Early cerebritis from 0 to 3 days, late cerebritis from 4 to 9 days, early capsule formation 10 to 14 days, late capsule formation more than 2 weeks. In the CT scan, it appears as a homogeneous low-density mass with renal enhancement following contrast administration and extensive perifocal edema. The MRI on T1 weighted images, it appears as homogeneous low-intensity or iso-intense signal, on T2 as high-intensity signals, and restricted diffusion and diffusion-weighted imaging, and elevated lactate and glycerophosphocholine on MRS. Neurosurgeon's role, classic indications for aspiration: abscess larger than 2 cm in diameter, a risk of intraventricular rupture, failure of adequate antimicrobial therapy. Brainstem and cerebellar abscess may need posterior fossa craniotomy and decompression. Indications for open surgical excision of brain abscess: if a foreign body or bone chips are present, if the abscess are multiloculated, if fistulous communication occurs. Coming to infectious encephalitis, diffuse inflammation of the brain resulting from direct invasion by an infectious agent. Primarily, it is caused by viral infections. It causes fulminant necrotizing hemorrhagic encephalitis with predilection for temporal bones. In the imaging, the edema appears as hypodensity, which is predominantly localized in the temporal bone or orbitofrontal lobe and limbic system on CT scans. Enhancement may occur in the 2nd week. Here, the neurosurgeon's role is about brain biopsy for viral culture and histological examination, and CSF shunting for hydrocephalus if hydrocephalus occurs. Coming to pyogenic ventriculitis. Ventriculitis is the inflammation of the ependymal lining of the brain ventricular system. Pyogenic ventriculitis is characterized by presence of suppurative fluid in the cerebral ventricles. Coming to imaging, it demonstrates intraventricular debris and pus in the CSF on flare, periventricular high signal, and ependymal enhancements will be seen. Again, here CSF study shows a low glucose level, high protein, and pleocytosis. Neurosurgeon's role: when ventriculitis is unresponsive to intravenous antibiotics, intrathecal vancomycin or colimycin can be administered using an external intraventricular drain or an implanted device like an Ommaya reservoir. Concomitant brain abscess should be drained whenever possible, and when secondary hydrocephalus develops, CSF diversion should be done. Coming to orbital abscess, there are 2 types. They are subperiosteal abscess and true intraorbital abscesses. Subperiosteal abscess is the suppurative collection found along the orbital walls. True intraorbital abscess are the suppurative collection found in the extracornal and intracornal spaces. The periosteum plays an important role against the progression of the infection to the orbital space and later into the intracranial contents. Visual loss is the most serious local complication. It occurs due to corneal damage, persistent raised intraocular pressure, central retinal artery occlusion, or septic, inflammatory, or ischemic optic neuropathy. In the CT scan, it appears as low-density collection along the orbital walls or into the extracornal and intracornal spaces with contrast enhancing margin. Neurosurgeon's role is surgical drainage. The objectives of surgery here are drain the pus sufficiently, decrease intra-orbital tension, and take samples for culture. The indications for surgery are disease progression within 48 hours despite adequate antibiotic therapy, suspected visual compromise, abscess volume larger than 1250 cubic millimeter, significant proptosis, and craniotomy may be needed in patients with intracranial separations. Coming to Pott's Puffy tumors, it is an unusual form of cranial osteomyelitis. It's characterized by the association of localized forehead swelling with overlying extracranial subperiosteal abscess and underlying frontal bone infection. Erosion of the inner table of the skull results in cranial epidural abscess. Infections may progress deeply into the subdural space causing subdural empyema, into the subarachnoid space causing meningitis, into the brain parenchyma causing abscess or encephalitis, or into the dural sinus causing dural thrombophlebitis. The imaging cranial bone erosions are noticed on CT scan. MRI is useful in demonstrating intracranial and intraorbital complications, bone marrow edema, leptomeningeal enhancement, extradural and subdural collections, brain abscess, and sinus venous thrombosis. Neurosurgeon's role come as craniotomy for drainage and debridement. Infected bone with evidence of necrosis should be removed, followed by cranioplasty and a second intervention. Surgical site infections in cranial surgery. The depth of the surgical site infections are classified as subgaleal, cranial bone, epidural, subdural, and intracerebral. The risk factors are classified into two. One is patient-related and another one is procedure-related. Patient-related risk factors are diabetes mellitus, obesity, malnutrition, tobacco use, concomitant infection at another site, prolonged preoperative hospitalization, colonization with Staphylococcus aureus, compromised immune function, corticosteroid use, and old age. Procedural risk factors are inappropriate antibiotic prophylaxis, duration of surgery longer than 4 hours, implantation of foreign material, defective sterile technique, local radiotherapy and radiation and chemotherapy, leakage of CSF. Neurosurgeon's role: surgery is considered if there is abscess, empyema, and large cranial osteomyelitis requiring operation with cleaning, evacuation of fluids, debridement, removal of foreign material, and drainage. In intradural suppurative collections, medical therapy is considered if there is a small lesion, very limited infectious extension, no intracranial mass effect, no neurological deficits, and an early favorable response to antibiotics. Management of CSF shunt infections. It has to be dealt with surgical removal of the shunt, placement of temporary external ventricular drainage, intravenous antibiotic therapy, implantation of a new shunt system if needed when the infection has been eradicated. In all cases, if the hardware is involved with serious infection, the foreign material should be removed during revision surgery. Next, coming to brain tuberculomas. Brain tuberculoma may be solitary or multiple, with or without tuberculous meningitis. Tuberculoma is often infratentorial in children and supratentorial in adults. CT and MRI contrast enhancing lesions with extensive disproportionate perifocal edema is noted. The contrast enhancement may be either peripheral or uniform. Here, the MRS will show large lipid peaks, increased choline peaks, decreased level of NAA and creatinine, and choline creatinine ratio greater than 1 suggests brain tuberculoma. The indications for neurosurgical interventions in brain tuberculoma are to obtain a definitive diagnosis by biopsy, to relieve mass lesions if medical therapy has had no success, to manage high intracranial pressure, for CSF diversion in case of hydrocephalus. Next, coming to brain hydatid disease, intracranial hydatidosis, intracranial development of the larval cysts of the tapeworm Echinococcus granulosus. In CT, it appears as spherical, thin-walled, well-limited unilocular hypodense lesion without surrounding edema. There is no enhancement after contrast injection. In the MRI, it appears iso-intense to CSF on T1, T2, and FLAR images. Gadolinium enhanced T1 weighted images show no enhancement. Surgery role: surgical removal of the intact cyst is a cornerstone of treatment. Every effort should be made to prevent spillage of the cyst fluid and to remove the cyst completely. It is usually delivered by a procedure called Dowling's procedure. It is a spontaneous delivery of the intact encephalic cyst through a large craniotomy with a limited corticectomy. The cyst is delivered by forcing saline solution around the brain parenchyma by means of hydrostatic expulsion. This surgical hydrodissection of the cyst drain interface is performed by gentle irrigation with soft tip catheters. Irrigation of the operative field with colicidal solutions like hypertonic saline or oxygenic water may be used to prevent local recurrence. Here you can see the soft tip catheter and the cyst being delivered by means of hydrostatic expulsion. If accidental breakage of cyst occurs, adjacent tissues will be contaminated with possible future recurrence of multiple cysts. And also there is a risk of allergic reaction by way of anaphylactic shock is another complication observed when the intraoperative spillage occurs. Next, the other parasitic and fungal infections. Here, the surgery is indicated for biopsy for tissue diagnosis, decompression in case of raised intracranial pressure and mass effect, CSF diversion in case of hydrocephalus, and drainage in case of abscess formations. Thank you.
Okay, thank you.
It was a nice lecture, elaborate lecture from Dr. Valavan sir and Dr. Pradeep sir in CNS infections. Everyone had a lot of knowledge from all the interactions what we had. Let us have much more topics like this in future sessions. Thank you one and all. Thank you the winners
Next
and
time we
thank you
will
the
have.
East Formal
Next
for
we will.
sponsoring.
Next time we will have. Next we will have Tamil Nadu Medical Council credit hours also. Now we should make arrangement for that. With some organization, we will try to join and we will do it. Okay.
Sure. Thank you.
Okay.
Thanks a lot. Good night.
Thank you, sir. Thank you. Good night.
Thank you, sir.
Thank you, Valavan sir. Thank you, Pradeep
thank
sir.
Thank you,
Thank
sir.
you, Vikram sir.
Thank you very much,
It
sir.
was a nice session.